Yes.
Virendra Goyal, sir.
Hello. Yes.
Sir, Virendra, sir, make me as the host, sir. I'm unable to add Kulkarni madam to the panelist list.
Okay. You are otherwise you are boss. You don't need my permission.
Sir.
Okay. Let me find out where you are. Make host. Change host. Okay.
Yeah,
Is it okay?
done, sir. Okay.
And are we still live on Facebook? Let me check. Because sometimes what happens when we change the setting, then
Yeah, good morning, everyone. I'm extremely sorry for the inconvenience.
no, Dr. Parimala, good morning. That's
Good morning, Dr.
absolutely fine.
Parimala.
These are all
Good morning,
technical
Dr.
issues.
Madhu.
These are all
Good
people
morning,
happy.
Neerja ma'am.
Good morning,
Yeah, thank you very
Parimala.
much, sir.
Good morning, ma'am.
Good morning, Dr. Priya.
Good morning, ma'am.
Good morning, Dr. Parimala.
Good morning, Dr. Neeraj. Good morning.
Shall we start the session, sir?
Yes.
Yes. Mr. Srinivas, just take it off.
Very good morning to all the faculties and dear postgraduate students. We'll be starting the first session of day 2 of PediaRare 6. We have 3 eminent speakers, Dr. Indira M D, who is going to cover Caries diagnosis and Caries risk management. Dr. Neeraj Gugnani will be covering minimal invasive dentistry, and Dr. Priya Nagar will be covering the epidemiology of dental caries and early childhood caries. It's my pleasure to introduce the two moderators for this session, Dr. Parimala Kulkarni and Dr. NeerjaSingh. Dr. Parimala Kulkarni is presently working as the head of the department and dean at People's College of Dental Sciences and Research Center, Bhopal, Madhya Pradesh. She is also the member of Board of Management, People's University, Dean, Dental Faculty, People's University, and she is the co-editor of People's Journal of Scientific Research, People's University. She is immediate past president of Indian Society of Periodontics and Preventive Dentistry. She has been awarded as the Distinguished Women by ISPPD and Women of the Year by MPDCSS Women's Cell, a clinician with exclusive pediatric dentistry practice and an academician of over 23 years experience by mentoring undergraduates, postgraduates, and PhD scholars, and takes great pride in mentoring them. She has more than 80 publications in national and international journals, 9 patents, and 2 book contributions to her credit. Welcome, ma'am.
Thank you very much.
And we have the second moderator for the session, Dr. NeerjaSingh. She is a passionate pediatric dentist, currently working as professor in the Department of Pediatric and Preventive Dentistry at Babu Banarasi Das College of Dental Sciences, BBD University, Lucknow, India. She completed a graduation in 1996 and post-graduation in 2001 from the prestigious King George Medical College, Lucknow, and has a teaching experience of more than 24 years, guiding more than 30 dissertations. She is an active member of ISPPD SAAPD EAPD, IAPD, ICDS, and IDA. She has published numerous papers and case reports in peer-reviewed international and national journals. She completed a PhD in molecular identification of salivary proteins and other metabolites in children with early childhood caries. She is on the review panel and editorial board of indexed national journals. She has keen interest in procedural sedation, early childhood caries, child psychology, dental traumatology, forensic odontology, and pediatric orthodontics, and has been specially trained in nuclear magnetic resonance and mass spectroscopy, and has a passion for research work. Welcome, ma'am.
Thank you. Thank you so much.
Now I request Dr. Parimala to please introduce the first speaker of the day, Dr. Indra M D.
Good morning again, once again to everyone. It is really a pleasure to introduce Dr. Indira. So Dr. Indira is Assistant Professor in JSS Dental College and Hospital, JSS Academy of Higher Education and Research. She completed her BDS in 2003 and MDS in 2009 from JSS Dental College, and PhD in 2018 from JSS Academy of Higher Education. She has more than 13 years of academic and research experience in Department of Pediatric Dentistry. She has a life member for ISPPD and an annual member to the International Association of Dental Research. She's been awarded with received a fellowship in 2017 International College of Dentists, Best Paper and Best Poster Award in various national conferences, Research Training Award for from St. John's Research Institute, Bangalore, Bright Smiles, Bright Future Award from Preventive and Oral Health Community Program, Baby Oral Health Promotion Clinic by International Association of Pediatric Dentistry at 20 Congress of IAPD in 2021, have published more national journals. I welcome Dr. Indira.
Thank you, ma'am.
Yeah.
Can I have my presentation?
Good morning, one and all. Warm greetings from JSS Academy of Higher Education and Research. Myself, Dr. Indira from JSS Dental College and Hospital, will be presenting on caries diagnosis and caries risk assessment. These are the questions which have appeared in the previous year's university papers, from 50 markers to 10 markers questions. So we will move on to caries diagnostic aids. These are the questions on caries diagnosis, and these are the questions which have appeared on caries risk assessment. Diagnosis. Diagnosis refers to the process of identifying the nature and the cause of the disease, condition, or a problem. It involves gathering the information from various sources such as patient history, physical examination, and diagnostic tests to determine what is wrong. Coming to the caries diagnostic aids which are available, this can be broadly categorized as visual-based diagnostic aids, radiation-based diagnostic aids, light-based diagnostic aids, electric-based diagnostic aids, ultrasound-based diagnostic aids, and other digital diagnostic aids which are under development. You can also classify these diagnostic aids as conventional methods and recent advances. Under conventional methods, you have visual method, tactile sensation, illumination, dyes, and radiography. And all the others falls under the recent advances. So moving to the conventional methods. So the dental explorers have traditionally diagnosed caries lesions. However, the studies have shown that this method causes an irreversible harm to the tooth surface and favors the lesion progression. Dental explorers can disrupt the remineralization and transfer the cariogenic bacteria to the adjacent teeth. Further, using the dental explorers to assess the occlusal surface can result in misdiagnosis. A deep fissure that appears to be sticky occlusal surface can be misdiagnosed as a dental caries.
Sorry for interruption, Dr. Indira. Dr. Indira, sorry for interruption. Your
Yes, ma'am.
this voice is not clear and many people are complaining
Yes,
about
ma'am.
it. So
Yeah, even I'm feeling the same, ma'am. Voice is not clear.
Dr.
Yes.
Indra, is it possible? Are you having your PPT ready in your laptop?
Yes, sir, it is there. Shall I present it directly?
Yeah,
sir?
just present it live. I'll make you
Yes,
host.
sir. Sure, sir. Thank you.
Dave, just make Dr. Indra as the co-host and allow her to share her screen.
Sure, sir.
Okay, thank you. Yeah,
Madam, you can share your screen.
yeah, you can do it. You need to switch off the video, yeah, and let her share her screen. I appreciate the feedback from the attendees and we'll
So just
try
give
our
me-
best to manage it. Yeah,
Give me 1 minute, sir. I'll just share.
no
this.
problem, no problem. Take your time.
Yes.
Is it visible?
Yeah, ma'am. It's visible.
Yes, absolutely, it's visible.
Can I start, sir? Shall I start, sir?
Yes,
Yes, yes,
please,
yes,
please.
yes.
Yeah.
Morning, everyone. Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parbrahma, Tasmai Shri Guruve Namaha. I seek the blessings of my parents, Almighty God, and my teachers before starting this presentation. A warm greetings. Oops, sorry. Warm greetings from JSS Academy of Higher Education and Research. Today, I'll be talking on caries diagnosis and caries risk assessment. These are the questions which has appeared in the university papers on caries diagnosis. The main questions for 50 marker was advances in caries diagnosis, risk assessment and management. And for 10 marker, caries diagnostic aids. However, these are the questions which directly does not come under diagnosis. However, it comes under caries activity test and calorimetric test have also been appeared. These are the questions on caries risk assessment. So we'll move on to the caries diagnosis. So what is diagnosis? Diagnosis, it refers to the process of identifying the nature and the cause of disease, condition, or a problem. It involves gathering information from various sources such as patient's history, physical examination, diagnostic test to determine what is wrong. So how do we classify these diagnostic tests? So it can be classified as visual-based, radiation-based, light-based, electric-based, and ultrasonic-based. However, there are certain digital diagnostic aids which are under development, which we will be seeing in detail in the future slides. This is one more classification which is given in the textbook of Pediatric Dentistry by Nikhil Marwa. So he has classified as conventional methods and recent advances. So you can either classify when the question is asked in this way or in this way also. Conventional method. Dental explorers have traditionally diagnosed carious lesions. However, the studies have shown that this method causes an irreversible harm to the tooth surface and favors a lesion's progression. The dental explorer can also disrupt the demineralization and transfer the karyogenic bacteria to the adjacent. Further, using dental explorer to assess the occlusal surface can result in misdiagnosis. A deep fissure can appear as a caries and it can be misdiagnosed. Dental explorer should only be used to remove the stains and the soft tissue on the soft plug on the tooth surface, and visual examination always comes first when assessing the caries. You can also use a magnifying loops when you are using a mouth mirror and probe. The next method is caries detector dye. Although controversial, caries detector dye are used by many dentists to aid for the caries removal. How do they work? They work by staining the collagen, which is associated with the less mineralized dentin. However, they do not stain the bacteria, nor demarcate the infection front. So in a study on caries detector dye, it shows that the areas of the tissue with a greater concentration of organic material was also stained, regardless of it being caries-free. Hence, using caries detector dye routinely without a proper understanding of their limitation may lead to excess removal of sound dentin and mechanical pulp exposure. Many caries dye detector provide an irreversible staining. Their use for diagnosing occlusal caries is not recommended as it can be aesthetically unpleasant. The extent of demineralization can be relatively noticed by the intensity of the fluorescent dye, where a higher intensity correlates to the more demineralization. Moving on to the next diagnostic aid, that is the radiation-based diagnostic aids. The visual tactile examination of carious lesion is not sufficient for assessing especially the interproximal caries. Therefore, the radiography is commonly used to assess and detect the caries, as it gives the practitioner an additional information about the clinical progression. The X-ray, which is in the form of electromagnetic radiation with a specific wavelength ranging from 10 nanometer to 0.1 nanometer, was introduced in 1890s for detection of dental caries. Over time, the digital radiography has gradually replaced the conventional radiography due to its ease of image manipulation, enhanced image quality, and improved diagnostic accuracy. Clinically used radiation-based diagnostic aids encompass digital bite wings and cone beam computed tomography. So these are the two technology which we use for the diagnosis of caries, and these are the commercial products which are available. Coming to the digital bite wing radiography, it uses a photographic film or a digital detector to capture the image when X-ray interact with the emulsion on the film. The digital bite wing radiograph are often employed right after the clinical examination of the dental caries, especially for the proximal caries. This technology provides a qualitative diagnosis by enhancing the observation of the lesion extension or the density changes in the enamel or dentin over time, and allows for the long-term monitoring of the carious lesion. However, it comes with certain limitation. The routine use of intraoral radiographs, especially for the low carious risk patients, the use of radiographs is debatable. The radiograph also cannot distinguish between an active and an arrested carious lesion, and sometimes between the cavitated and also non-cavitated surfaces, as the radiographic lesion depth does not always reflect the actual carious lesion, because the radiograph only detects the lesion with the depth of at least 500 micrometer in the enamel. The inability to detect the initial carious lesions limits its use in the clinical setup. So, the sensitivity and the specificity of this diagnostic aid is as shown in the table. Moving on to the CBCT, known as cone beam computed tomography. It utilizes a cone or a pyramid-shaped X-ray beam with mostly flat panel detectors to construct a three-dimensional high-resolution image that can be viewed in the frontal, sagittal, as well as the axial plane. The main benefit of this technique is that it can overcome the limitation of two-dimensional imaging, which we saw in the which is two-dimensional image of the bite wing radiography. The accuracy of CBCT in detecting the dental caries has shown considerable variability across the different studies in the literature. The sensitivity and the specificity for detecting the proximal lesion is 0.7 to 0.79 in the as shown in the clinical studies. However, the CBCT are not advised as a primary diagnostic tool for a routine caries detection. Moving on to the light-based diagnostic aids, The light-based diagnostic aids employ various types of lights or laser to generate signals and detect the changes in the signals in the caries tip. The three major categories of light-based diagnostic aids are digital transillumination, light-induced fluorescence, and laser-induced fluorescence. So these are the commercial products which are available under light-based technology. If you can remember one or two names, you can mention it when you're writing your theory paper. The digital transillumination, transillumination is a technique of transmitting the light through the body tissue and assessing the density and composition of the tissue through the intensity of the light. The traditional fiber optic transillumination cannot produce an image and only allows an instant on-site interpretation of the examination result. To address this issue, the digitalization was being incorporated. The most common light source for digital transillumination is invisible near-infrared light oscillating between 700 nanometer to 1500 nanometers. This light can penetrate deeper into the dental tissue due to the reduced scattering and absorption compared with the visible white light in traditional transillumination, resulting in a better contrast between the healthy and the caries tissue. The digital transillumination is especially useful when you are detecting for the proximal. The digital transillumination has the benefit of lower radiation dose, reduced patient discomfort, real-time image viewing, and overall high feasibility than the visual examination and radiography. Digital transillumination cannot accurately reveal the lesion's volume, mineral content, or caries activity because it cannot distinguish the caries lesion from the developmental defects such as fluorosis, and it may lead to overdiagnosis or overtreatment. This is the limitation of digital transillumination. Again, the sensitivity and the specificity of this diagnostic aid is mentioned. Moving on to the light-induced fluorescence, light with again various wavelength, which I have mentioned previously. These light has been used varying from 700 to 10,000 nanometers. Fluorescence is a type of illuminescence or emission of light of longer wavelength from a substance after absorbing the light or other electromagnetic radiation at a shorter wavelength. The use of fluorescence in caries detection is based on the phenomena that the caries lesion have altered fluorescence properties compared with that of the sound dental tissue. So when a caries lesion absorbs the light of shorter wavelength, it emits the light at a longer wavelength, creating a color change during the process. Light-induced fluorescence can be applied for multiple surfaces on the tooth, including the occlusal surface, buccal or the lingual surface, as well as the proximal surfaces. It enables the quantification of mineral loss in the caries lesion by capturing the average loss of fluorescence in the caries tissue compared with that of the sound enamel and converting the loss of fluorescence into a mineral density. It also has the benefit of lower radiation, reduced patient discomfort, real-time image viewing, and storage compared to that of the visual examination and radiography. The limitations of light-induced fluorescence is it cannot be applied in the areas where light cannot access directly, such as proximal surfaces of the posterior teeth. Moreover, because the light might induce the generation of fluorescence from subjects other than the caries teeth in the oral cavity, the interpretation of the for the detection of the result should be careful to avoid the over-diagnosis. Laser-induced fluorescence. Laser is light amplification by stimulated emission of radiation, employs the red light laser at a wavelength of greater than 655 nanometer to stimulate the fluorescence in the caries tissue. It is an electromagnetic wave generator that produces a single wave of light and focuses on a narrow beam. The laser-induced fluorescence derived from protoporphyrin, a photosensitive pigment resulting from bacterial metabolic activities in the caries lesion to facilitate the caries detection. Because healthy dental tissue produces little or no fluorescence, the emitted fluorescence intensity correlates with the caries severity. Laser-induced fluorescence can detect the caries lesions from the various tooth surface as the light-induced fluorescence, like from occlusal surface, smooth surface, as well as the proximal surface. It can estimate the depth of caries lesion and display the value on the monitor from 0 to 99. in which the lower scores indicate the healthier tissues and higher scores reflect the need for restorative treatment. The advantages include, again, the lower radiation dose in reduced patient discomfort, real-time chairside detection compared with that of the conventional methods. Laser-induced fluorescence has the risk of generating a false positive results, which might lead to the overdiagnosis. It is presented with the sensitivity of 0.4 to 1 and specificity of 0.2 to 1. The laser-induced fluorescence is recommended to be used as a supplementary diagnostic aids instead of a primary tool for detection. Moving on to the next diagnostic aid, that is the electric-based diagnostic aids. The use of electricity to detect the caries was first proposed by Emil Megitot in 1878. Electric-based caries detection device works based on the phenomena that hydroxyapatite, which is the main component of dental enamel, has a higher electrical resistance. When cavities occur, the porosities in the dental hard tissue increases in size and contain more electrically conductive fluids from the oral cavity compared with that of the sound teeth. Since the porosities are filled with the ionic fluid, there is a decrease in the electrical resistance and an increase in the electrical conductance. So the electric-based caries detecting approaches can be categorized into electrical conductance measurement and alternating current impedance spectroscopy. So these are the two technology under electrical based. Again, the examples of the commercial products are mentioned here. The electrical conductance measurement. The electrical conductance measurement device is a single fixed frequency alternating current to measure the electrical conductance of the caries. The measuring electrode is designed to fit into the deep fissures to be in contact with the minuscule amount of dentinal fluid to complete the circuit. If there is no caries present on the tooth and has an intact enamel, the circuit of the current flow cannot be completed, making the reading on the device as zero. If the lesion is present, then the flow of the current would be present and the circuit would be closed, which provides a reading on the device. The electrical conductance measurement device allows for the detection of both cavitated as well as non-cavitated lesion on all the tooth surfaces. This diagnostic aid can differentiate the caries as well as the stain. However, there is still much discussion on the cost and the feasibility of this technology. An in vitro study was conducted which showed that electrical conductance measurement device demonstrated a high sensitivity value of 1 and specificity value of 0.9 in detecting the early occlusal caries. The next is the alternating current impedance. It measures the impedance or the resistance of the teeth to the alternating current. This detection method utilizes the multiple frequency of electricity to produce a spectrum of values, providing more information on the physical and the chemical properties of the tooth. The next method of diagnostic aid is the ultrasound-based diagnostic aids. The ultrasound has been used in dentistry as a diagnostic tool for caries detection by detecting the difference between the sound and demineralized hard tissue through the sonic conductivity of longitudinal ultrasonic waves. So this technology is the ultrasonic caries detector, which is commercially available product. So in this detector, there is a probe which can be placed at certain angle to detect the caries lesion, particularly the proximal caries lesion. The ultrasonic caries detector are relatively simple because of the ultrasonic waves are amplified and are simply greater than that of the background level, allowing for the easier interpretation of the wave profile. However, the ultrasound has been reported to have a low spatial resolution, deeming to be less competitive. Also, it cannot measure the depth of the caries lesion. Moving on to the last component of the diagnostic aids, that is the digital diagnostic aids, which are still under development. The first one in this category is the optical coherence tomography and laser-related caries detection. The optical coherence tomography produces 2 or 3 dimensional images based on the tissue's optical resorption and the scattering properties. The swept source OCT, that is swept source optical coherence tomography, can be used for caries detection. It has an increased image resolution, speed of the image, and sensitivity compared to that of the traditional OCT system. This system images of caries detection, demineralized enamel or dentin is presented as a bright zone due to the increased backscattered signal from the caries tooth structure. Although there is a current in vivo research of OCT is Caries. One in vivo study compared the OCT with the bite wing radiography and confirmed that SSOCT is more reliable and accurate when detecting the proximal caries. However, this technology is still under development and commercial product is not available. Next is the laser-related caries detection. The laser-related caries detection, apart from laser-induced fluorescence, laser can also be used to induce signals for caries detection. So the laser can induce the signals through thermal signals, acoustic signals, phototonic signals, etc. on the tooth surface to facilitate the caries detection. However, this technology is again under development and no commercial products are available yet. Hence, to summarize the diagnostic aids, the digital diagnostic aids for dental caries detection has been evolving. The radiation-based, light-based, ultrasonic-based, and electrical-based are available as a digital diagnostic aids for dental caries detection. These available diagnostic aids present advantages as well as certain levels of limitations. They facilitate caries detection for clinicians by acting as a supplementary approaches to the conventional caries detection. However, none of them have presented an ideal performance in detecting the dental caries, especially for the incipient caries. Therefore, various novel digital diagnostic aids for dental caries are still under development and has shown a potential for clinical application. So here I completed the presentation on caries diagnosis. Now we'll move on to the caries risk assessment. Caries risk assessment. There are various risk factors for development of early childhood caries. One of the systematic review by Priya et al. Have shown that there are 123 risk factors for the development of early childhood caries. Among these 123 risk factors, what they concluded is the two strongest risk factors are the presence of enamel defect and high levels of mutant streptococci. However, the secondary risk factors are the presence of dentinal caries, frequent consumption of sweetened food, poor oral hygiene, and presence of visible plaque. For the ease of caries risk assessment, they have categorized these risk factors into risk factors, which is social and behavioral, risk factors, which is clinical, and the protective factors. The balance between these risk factors and the protective factors gives you how to assess whether the child belongs to the low risk, moderate risk, or the high risk categories. So the caries risk assessment tool is a research-based tool to identify the risk factors that causes the dental decay. So there are various caries risk tools which is available. These are the few list of caries risk assessment tools. Among them, the most commonly used are ADA, AAPD, AAP, camera, NUSCRA, as well as probably and CMS system. These are most commonly used caries risk assessment tool. So here in my presentation, I will just cover few of them. So this is the ADA, American Dental Association caries risk assessment tool, where they have categorized the risk factors into contributing conditions, general health conditions, and clinical conditions. So depending upon the child's yes or no, they fall into category of low risk, moderate risk, and high risk category. The next is camera, that is caries management by risk assessment. So there are two cameras which are available. The first was proposed in 2011, where they have categorized the factors into risk factors, which is again biological or predisposing factors, protective factors, and disease indicators. Again, the balance between these factors, that is the protective factors and the risk factors, it gives you an assessment whether the child falls into which risk category. So this has been modified into camera 1, 2, 3. Okay, this is published in 2021. Again, the same factors have been used, except that they have used one extra factors compared to the previous one. Here there is risk factor, protective factors, and disease indicators, whereas here they have categorized into biological risk factors, protective factors, biological risk factors on clinical examination, and disease indicators. So what is the main difference between camera and camera 1, 2, 3 is the camera is more of qualitative. You have to just mark whether yes or no, and you have to assign the child into a risk category. Whereas here it is more quantitative. For example, if you're assessing, when you are assessing, for example, if I take the child has a frequent snacking, like if the child is snacking more than 3 times a day, if it is yes, though you have to put a score of 2. Likewise, you have to put a score on each box if it is yes, and total those scores in each column and add those total. So based on this total score, if the total score falls between -4 to -1, it is categorized as a low risk. If it falls between 0 to 3, it is categorized as moderate risk. If it is, the score is between 4 to 13, it is categorized as high risk. And between 14 to 18, it is categorized as very high risk. So this is camera 1 to 3. Now moving on to the AAPD, American Academy of Pediatric Dentistry protocols. This is 2019 Caries risk assessment form, and this is the latest 2022. So what is the main difference between these two from the 19 to 22 is here they have categorized as risk factors, protective factors, and clinical findings, whereas in 22 they have categorized risk factors into behavioral factors and risk factors clinical. Again, the protective factors and disease indicators remains the same. One more important caries risk assessment tool is CRAFT. Because why this is important? Because this has been developed by our own pediatric dentist, that is Dr. Ashwin sir. So what this CRAFT stands for? CRAFT is Caries Risk Assessment for Treatment. It is a chairside, non-invasive, simple method for assessing the caries risk in children. In this, it uses the 4 segments, that is diet, decay status, fluoride exposure, and other factors. And based on yes or no, you can categorize into 4 categories, that is very low or no risk, low risk, moderate risk, and high risk category. Next, moving on to the next caries risk assessment tool, cariogram, which has appeared as a question in your university paper. So cariogram, it was introduced in 1996 by Brathal and Peterson. It was designed to predict the individual's risk and guide the personalized preventive strategies. Unlike traditional approaches, they rely on isolated risk factors such as bacterial counts or fluoride exposure. The cariogram integrates multiple determinants of caries development, including the dietary habits, oral hygiene practices, bacterial levels, salivary properties, as well as the systemic health condition. And it gives an output in the pie chart form, representing the probability of avoiding the caries. There were 2 studies. One is by Kegety, found that there was a significant correlation between the cariogram outcomes and the actual caries experience, confirming its predictive value for adults over 2 years period. One more study by Peterson emphasized its ability to distinguish high risk from low risk individuals and allowing for a targeted preventive measures. So this is how the cariogram output looks, where it gives the output in 5 colors. The green segments, the red segment, blue segment, dark blue segment, and a yellow segment. So what does these represent? Green segment represents the chance to avoid a new carious lesion. The red segment represents the actual disease. The blue segments, the light blue segment represents the diet. The dark blue segment represents the bacteria, and yellow segment represents the susceptibility to caries. So these are the factors and these are the functions. So these dietary factors include sugar intake frequency and track the intake of sugar or sugary foods on day or beverages daily. Then the bacterial factors include the levels of mutant streptococci and lactobacillus identified through the salivary testing, as these bacteria are primary contributors for enamel demineralization. The susceptibility factors includes the fluoride exposure, salivary flow rate, and salivary buffering capacity. The circumstances include the caries history and systemic conditions. Now, coming to what are the advantages of cariogram model. There are main 4 advantages of cariogram model. One is it is the holistic risk assessment. It provides a customized care, and it is effective for patient education, and it can have a tracking and evaluation method. Why it is holistic risk assessment? Because it includes multiple risk factors, unlike the other caries risk assessment tools. Why customized care? Because it gives a personalized treatment by identifying the key contributor. For example, if the patient with poor dietary habits, but he has got an adequate salivary flow, would benefit more from the dietary modification rather than giving him a salivary stimulants. So likewise, it can be customized for each patient based on the pie diagram. And it is an effective patient education. So if you take a CRA form and just stick it and tell them that you are having moderate risk or a high risk. Is my presentation visible? Sorry.
Yes,
Yes, it's
yes,
visible.
yes, it is visible.
It's visible, Dr. Indra.
So thank you. Okay, I was talking on effective patient education. So rather than showing the form and telling you belong to low risk, high risk, if you show it through a pie chart, it was more influencing. So the patient can correlate their risk assessment more effectively than on the paper. And for tracking and evaluation, the cariogram enables for a continuous monitoring changes in the caries risk over time. So the patient might be at high risk at the initial stage, and you can track those changes by when you give the preventive therapy, and after 6 months you can show that from the high risk and you have gone to the low risk, and what are the factors has influenced for you from going from high risk to a low risk. You can tell that effectively. So what are the applications of cariogram? So in the pediatric dentistry, it is highly effective in assessing the caries risk in children who are more susceptible to dietary and bacterial factors. For orthodontic patients, orthodontic appliance complicate the oral hygiene and increases the risk of caries. The cariogram identifies at-risk individuals and facilitates the interventions. In the geriatric dentistry, there is a reduced salivary flow and health conditions are challenging, so making them more vulnerable to caries. So the cariogram aids in the risk assessment and informs interventions such as fluoride treatment and salivary substitutes. And it is also helpful with the patients with special healthcare needs. So these are the few studies. I'm not going to read this. So when you are writing the cariogram, if you can mention these few studies, your answers will be more impactful. So to conclude, the cariogram model is well-established risk assessment tool that can be effectively utilized in low resource settings to evaluate the burden of dental caries in the population. Its integration into clinical practice and dental health education system is essential for providing valuable insights into caries prevention. However, there is one systematic review to assess the methodological quality of studies where they state that among all the caries risk assessment tool, the NUSCRAD, that is the National University of Singapore studies, reported that the most information to inform the assessment of its measurement properties, and as a result, this tool attained a higher quality rating than any other caries risk assessment tool as studied. There is one more study which compared the camera 123 and AAPD. So they did a comparison of this camera and AAPD. The main difference between these two is in camera 123, it considers the medication induced hyposalivation, whereas the AAPD does not take this factor into consideration. Camera 123 does not take immigrant children with special healthcare needs, and children with enamel dental defects into consideration when they are assessing the risk, where actually the dental defects is one of the highest risk factors for the development of dental caries, as I mentioned, as proved in the systematic review and a meta-analysis. And also the study concluded that there is a need to establish a caries risk assessment tool which is exclusively for the children below 2 years of age, because there was a lot of ambiguity in assessing the caries risk for the children between 0 to 2 years. So all the caries risk assessment tools gives from 0 to 6 years, but these risk assessment tools, there is a lot of ambiguity in applying for 0 to 2-year-old children. However, this also has certain limitations. The past caries experience is not particularly useful in young children, and activity of the lesion may be more important than the number of lesions. Low salivary flow is very difficult to measure and may not be relevant in the young children. Frequent sugar consumption is hard to quantitate. Socio-demographic factor are just a proxy for various exposure or behavior which may affect the caries risk. the predictive ability of various risk factors across the lifespan and how risk changes with age have not been determined. And genome level risk factors may account for sustainable variation in the caries risk. So these are the few limitations of CRA. So once you do the CRA, you categorize them into low risk, moderate risk, and high risk. And this is the caries management pathway. So what are the diagnostic tools you have to do, how much fluoride exposure, dietary counseling, and restorative intervention. So if a question is asked on caries risk assessment, just don't stop with caries risk assessment alone. Okay, you have to write how do you manage once you assess these risks. So if you can add this, you will be adding more value to your answer. So with this, I complete my presentation. I thank you all. Thank you ISPPD for giving me an opportunity to present in this platform. And I thank Dr. Madhu sir from Cayley Institute and all the pedo team from Cayley Bangalore for providing an opportunity to present in this platform. Thank you all. I also like to acknowledge my institution, JSS Academy of Higher Education and Research, for constantly motivating me to do research and academic work. Thank you so much.
Thank you so much, Dr. Indira. It was a wonderful lecture. I think students benefited a lot from this. There are few questions if you want to take it right now.
Ma'am, if there is a shortage of time, I would them later, or I don't mind if there is no shortage.
Okay, you can Dr. Parimala. Dr. Madhu. Dr. Madhu.
Yes, madam.
Yes, we have one question.
Yes, sir.
Which among these latest advancements accurately detect incipient dental caries?
So that's what I mentioned. None of the diagnostic as of now which are available is able to detect the incipient caries. However, the recent diagnostic aids which I told SSOCT, those are detecting the initial caries, but the product is not yet available, commercially available. So those recent ones have the potential to detect, but they are still not commercially available for the clinical use.
Okay, thank you. Thank you so much, Dr. Indira.
Thank you, ma'am.
I think we can move to the next one now.
Thank you, Dr. Indra.
Thank you, sir.
Now I request Mr. Dev to please project the certificate of appreciation to Dr. Indra. Yeah, thank you.
Thank you.
Now we have the second speaker, Dr. Neeraj Gugnani, and I request Dr. Nirja ma'am to please introduce the speaker.
Good morning, everyone. This is a great pleasure for me to introduce Dr. Neeraj Gugnani, who's a wonderful professional and a superb senior to me. Dr. Neeraj Gugnani is working as a professor at the Department of Pedodontics and Preventive Dentistry, DAV Dental College, Nagar, India. He completed his MDS from King George's Medical College, Lucknow. He has also done an MSc in clinical trials from the London School of Hygiene and Tropical Medicine and a PGCILT, a master's degree in higher education from the University of London. Recently, he has also completed an MSc in Artificial Intelligence in Healthcare from the University of Alcalá, Spain. He is a devoted researcher with a keen interest in academics and has won many awards and accolades in his career. He was awarded a Commonwealth Scholarship in 2008 and joined the Dental Health Unit, University of Manchester, UK, for research in the field of dental caries. He was also awarded the ORCA Travel Fellowship Award for the year 2011 by the European Caries Research Organization. He has delivered scientific presentations on many international and national platforms. He enjoys conducting courses and workshops on various topics, including cariology, artificial intelligence, research, biostats, clinical trials, systematic reviews, special child care, early age orthodontics, and dental trauma. Dr. Gugnani has more than 90 publications to his credit and is a member of many scientific societies, including IADR, ORCA, IDA, ISPPD, ISDR, etc. So I'm sure this session is going to be very fruitful for our students. Over to you, Dr. Neeraj Gugnani, sir. We all welcome you.
Neeraj sir, please unmute.
Sorry for that. Thank you, Dr. Nirja. Thanks a lot for the introduction. And before, at the very outset, I convey my sincere thanks to Dr. Madhu and his team, Dr. Srinivas, Dr. Ravi Kumar, Dr. Kirti, Dr. Virender, and the ISPPD head office headed by Dr. Virender Goyal and Dr. Shashikiran sir, and my chairperson, Dr. Parimala and Dr. Nirja for this presentation. May I request Dr. Virender to, will my video will be showcased or should I do the slide share and present?
Sir, we'll take your video, sir. Video, audio, any issues?
Okay.
Is it live?
Okay, no problem. I'm ready for both. Yeah.
Okay. Sir.
Good morning, everyone. First of all, I would like to convey my sincere thanks and gratitude to Dr. Madhu and his team at KLE Institute of Dental Sciences, Bangalore. I also convey my sincere thanks to ISPPD head office for inviting me for this wonderful CD on virtual PediaRare, that is rapid revision course for the postgraduates from Pan India. Today, I'll be speaking on minimal invasive dentistry. I also convey my greetings from my own dental college, Department of Pediatrics and Preventive Dentistry at DAV Dental College, Nagar. So, before we start, let's understand a few basics. Despite the progress made in caries prevention and control, it is still one of the most prevalent diseases. Globally, it is known to affect about 50 to 90% of children, and the prevalence of ECG in
Sir,
India
sorry,
has
sir.
been reported to
Neeraj,
around
sir.
50%.
Yeah. Neeraj, sir, just 1 minute.
Dental caries, as we
audio-
all know, is associated with oral pain, infection, eating and speaking difficulties, malocclusions, absentees from schools. It leads to poor quality of life, and the list is unending. The video is controlled by Dr. Virender Goyal, sir. Really habituated to provide surgical care, which involves drill and fill approach, which is also called as surgical model of caries management. But in yesteryears, our approach has shifted to the medical management of caries management. This is a holistic model, but a subset of this holistic model is also referred to as minimal invasive dentistry. Now, philosophy of behind minimal invasive dentistry is three-pronged. First is it involves preventing the formation of new caries lesions. Then stop the progression of early caries lesion, reducing the need for restorative care, specifically for non-cavitated early white spot lesions. And thirdly, when the lesion is already cavitated, we use principles of minimal excavation and then restore with materials that inhibit secondary caries formation. So we, at every aspect, we try to restore, or we try to take steps when we do not have to excavate more any of the tooth structure in invasive manner. So these three strategies can also be called as non-invasive methods, micro-invasive methods, and minimally invasive excavation procedures. So this is the basic philosophy around minimal invasive dentistry. So for postgrads, whenever the question or the essay comes, your answer can start from the basics about cariology, and then you can come to caries risk assessment, and then suddenly you can shift towards what is the three philosophies behind MID. Now, any one of you, if is deeply interested in learning about the principles about MID, can refer to this paper, which involves when to intervene in the caries process and depicts what are these three strategies called as. Just to take an excerpt from this paper, these strategies involve non-invasive strategies. What is the meaning of non-invasive? We do not remove dental hard tissue. So we are not invading to any of the, we are not impacting, we are not invading any of the enamel. So we are not touching any acid etchant, we are not touching the burr, we are not touching the spoon excavator, nothing. We are not excavating anything. So it do not intend to remove any dental hard tissue. Micro-invasive means we are removing the dental hard tissue only at the micrometer level. So it will definitely involve some kind of use of acid agents like sealing, like infiltration techniques. Now, minimally invasive excavation strategies would involve removing gross dental hard tissue, but again applying the principles of minimal invasive dentistry. So we will not make deeper cavities. We will not tend to approach to the sound dentine while excavating the caries tooth structure. So these are the three different strategies that are involved in the MID, that is the minimal invasive dentistry. Now we'll discuss them one by one, starting with the non-invasive strategies. The overall intent of using these strategies is to encourage an ecological change that favors the remineralization. Now, this is the holistic chart that explains what is entailed under the non-invasive strategies, micro-invasive strategies, and minimally invasive strategies. As you can see in the non-invasive strategies, we are trying to make an ecological shift in the oral cavity, which is dependent upon the biofilm control, the dietary control, and the mineral control. So we target all the three factors which can lead to dental caries. And in one way or the other, we use different strategies to make the oral cavity, the oral environment in such a way that it shifts towards remineralization and not towards demineralization. In micro-invasive strategy, as I already told, we tend to use some kind of etchants, and because of that, we invade the mineral of the enamel only to the micrometer level. And in the minimal invasive strategy, we will discuss about ART, non-restorative caries control, stepwise caries excavation, and so on. So coming to them one by one, starting with the brushing. Now, tooth brushing is generally considered to be a factor of prevention. But when we talk about tooth brushing in terms of minimal invasive dentistry, we are focusing on its usability for remineralization properties. So prevention and MID or non-invasive strategies of MID are usually overlap, but their user cases might be a little different. When we make a strategy which is customized to a patient, it comes under the ambit of minimal invasive dentistry, specifically non-invasive strategies. But when we just teach, or when we go to a school, when we go to a dental camp, we teach on a holistic level, on a whole level in the class, that becomes under the ambit of the prevention. So toothbrushing is no doubt a fundamental self-care behavior for the maintenance of oral health, that is for prevention. But brushing with fluoride also help in remineralization of those early lesions. So it comes also under the non-invasive strategies of minimal invasive dentistry. So it disrupts the biofilm, of course, because of brushing, and it also recharges the plaque with anti-caries agent. Here we are talking of fluoride only, but we know that we can use different strategies with different chemicals within the toothpaste, like hydroxyapatite, like Novamin. So a toothpaste can recharge the plaque with different anti-caries agents, whichever is within the dentifrice. So important factors to consider while toothbrushing is frequency, duration, and the amount of fluoride in the toothpaste, and the amount of toothpaste also. So whenever you are making a customized non-invasive care plan, or you are trying to manage a patient with using the principles of non-invasive strategy, you need to consider all these factors about toothbrushing, and these should be objectively explained to the patient, and on each recall they should be objectively reassessed, the need, and if the patient is really following all the compliance or not. In terms of amount of fluoride in the toothpaste and amount of fluoride in dentifrice, we need to know that minimum recommended concentrations as per WHO is 1000 ppm. In India, it's only up to 1000 ppm, but in West, it is also 1500 ppm. And for high caries risk patients, even toothpaste or dentifrices are available up to 5000 ppm. So in terms of amount of toothpaste, we all know that for less than 2 years, we recommend rice smear. For 2 to 6 years, we recommend pea-sized. 6 to 12 years, 3 by 4th of the length of a bristle, and for more than 12 years, full length of the bristle. So the intent is that we do not want to expose the children to the risk of dental fluorosis, but we want them to be exposed to minimum of 1000 ppm. So twice daily brushing for 2 minutes each time with a minimum of 1000 ppm fluoride is what is recommended. The only thing that you can use is the amount of toothpaste and not the amount of fluoride in the toothpaste. So rinsing after brushing, we are habituated again to use a hand cup or a mug But when we try to rinse thoroughly, then the fluoride, whatever we have used, gets washed away. Instead, it is recommended to rinse with a wet toothbrush that helps to retain the fluoride. And even in children, it is more important because the children have a tendency to drink water, because of which the ingestion of fluoridated toothpaste becomes even more. So it's important that we can clean the after brushing, we can take a wet cloth to clean the child's teeth, or slowly and slowly we can train them to use a wet toothbrush so that some amount of fluoride retains in the oral cavity and is available always for recharge. So coming antimicrobials and probiotics. So biofilm control can be done by various steps. The second is the antimicrobials. The antimicrobials are aimed to reduction for different bacteria, specifically for mutant streptococci. This is available as varnishes, gels, and mouth rinses. Combination of chlorhexidine with fluoride, with xylitol, and different agents are available for caries remineralization or prevention, specifically indicated for high-risk patients. All the patients do not require use of antimicrobials, but brushing, which we discussed earlier, is required for everyone. So brushing with a fluoride toothpaste is recommended for everyone, but not everyone requires antimicrobials. But specifically for high risk or medium risk patient, depending upon the case to case. So that's why we say it's a customized approach of non-operative caries management. So it includes povidone iodine, chlorhexidine, fluoride, xylitol, or the combinations. So there are various studies. So whenever you are writing an answer, you should also be able to quote some studies. So there are various studies which clearly shows that the combination of povidone iodine with fluoride, or only povidone iodine, or only chlorhexidine has depicted good evidence against MS reduction, that is the mutant streptococci or lactobacillus reduction. So as you can see, this forest plot clearly shows that. And again, this is a forest plot which shows that the combination of these chlorhexidine and povidone iodine with or without fluoride also leads to reduction in the early childhood caries. So when we consider only the bacteria, we are taking a surrogate marker, but when in a study we measure directly the impact of an intervention on the caries, it is a direct measure, and we are able to understand that these antimicrobials are able to reduce ECC as an outcome. So probiotics, which is another form of strategy used for the non-invasive, which is included in the non-invasive intervention, it includes use of live organisms, and it works by replacement therapy. What is the meaning of replacement therapy? That whenever you use probiotics, which are healthy bacteria, they tend to replace the pathogenic bacteria. Thus, the oral cavity, the ecological shift goes towards the remineralization, because now the bacteria which are present in the oral cavity are more physiologic, which the metabolism is more towards remineralization and not towards demineralization. So it leads to decrease in the bacterial counts. Now again, we are only counting the bacteria. It is a surrogate marker, beneficial to prevent or treat oral diseases, mainly in caries and the gingival disease. Again, this is a forest plot very clearly showing. This is the participants which reduced as mutants. So you can see that this diamond blob, this summary of this whole forest plot is clearly showing that the use of probiotic leads to reduction in the S mutants count, and similarly leading to the reduction in the lactobacillus count, and also decrease in the risk of new lesions when the probiotics are used. So definitely, but there are concerns of washout. So if the probiotics are not used for a long time, so specifically for high risk patient, probiotics are indicated to be used in conjunction with other strategies, other non-invasive and micro-invasive strategies, to decrease or to make the ecological change in the ecological shift. Slowly and slowly, the other factors take over, and then you can shift towards only using of the fluoridated toothpaste. So next is the dietary measures. We all know that sugars or carbohydrates cause dysbiosis. So whenever a long question comes, it's important that you make this diagram, because this is a very important diagram which clearly shows our current understanding of caries and how the use of sugars, the use of sugars leads to caries, and no sugars leads to no caries. So fermentable carbohydrates forms the acidic production. So because of which the neutral pH, there is an environmental shift towards the low pH. Now, whenever there is low pH, the bacteria which are able to sustain in the low pH becomes more in number, and the bacteria which were able to sustain in the neutral pH becomes less in number. So that's why there is an ecological shift. That's why the health becomes the caries. So oral disease starts. So this diagram basically dictates us why reducing the amount and the frequency of sugars is important, because these are the sugars which lead to dysbiosis. So when you can then shift towards making a note on disaccharides versus polysaccharides, and we know that sucrose, that is the disaccharides, are the most arch criminals, mainly the sucrose, because they are able to, the oral bacteria are able to ferment them. Three factors regarding diet pertaining to caries are very important: the frequency of caries, consistency of food, time of clearance. So we know that the frequency is more deterrent, but frequency and amount are usually inseparable concepts. Then consistency of foods, that means sticky foods or fibrous foods. Time of clearance, we all know that the more the time the bolus is contained is within the mouth, and the more the chances of caries. That's also called as the fourth factor of caries, or the newborn factor. Now, after the biofilm and the dietary control, the basic we should shift towards mineral control. So from biofilm and the dietary, which included the external environment, now we are trying to strengthen the tooth itself. That is the third factor. So fluorides, we know that the fluoride has always been the pivot of caries prevention, and of course the control also. So it is able to prevent new caries and also to control the overall process. So it has been advocated to be used as either a systemic or topical route, but now we are very sure with the research that topical effects are more beneficial than systemic, and topical fluorides are recommended to be used on daily basis, twice a day, specifically in the form of dentifrices for all the patients. And if the patient is high risk, then or medium risk, then we can also indicate a use of professional fluorides in addition to the home care fluorides. So there are topical fluorides which include home care and the professional, and depending upon the caries risk activity, these fluorides are indicated. So professional topical fluorides includes gels, varnishes, and solutions. These are the couple of examples which we use in our department, and these are the different strategies by which you can apply the fluoride: use of foam trays, applicator tips, applicator brushes. And for all children about 2 years of age, we can apply a varnish or a gel twice a year, only twice a year. But if the patient is of high risk, we can even increase the frequency, that is as per AAPD guidelines. So again, home care for everyone every day, professional for everyone, specifically medium and high risk, 6 monthly. If the patient is high risk, you can even increase the frequency. So Riemann potential of professionally applied fluorides, again the research clearly shows, this is the forest plot which shows that the diamond blob is very much away from the zero, that is the line of no difference. This is the vertical line of no difference, which clearly shows that all the studies have depicted that the use of fluoride, professionally applied fluorides, is able to provide remineralization effect. And that's why for all the patients with white spot lesions, this non-invasive strategy is indicated. Non-invasive means we are not removing any of the enamel structure. Now, very important aspect is non-fluoride topical remineralizing systems. It is also called as NFTRAs or NFTRA, that is non-fluoride topical remineralizing agents. So most commonly is the GC Toothmousse, ClinPro Toothmousse Plus. That means based upon casein phosphopeptide or amorphous calcium phosphate, or on functionalized tricalcium phosphate, that is the ClinPro Toothmousse. So in addition to that, nowadays, based on enamelon technology, we have Oral-B Pro Expert. In addition to that, based upon different biomimetic systems like peptides, we have Curodont Repair. Based upon nanohydroxytide peptide, we have AppGuard. So there are different systems available which includes use of non-fluoride remineralizing agents. There is a shift occurring worldwide which is basically depicting that the fluoride usage can lead to dental fluorosis, and there are other concerns of fluorosis. So that's why a group of researchers is now recommending use of non-fluoride remineralizing systems. Some recommend with the fluoride, that means using a remin agent with fluoride, but other group of researchers is indicating use of a complete non-fluoride, zero fluoride remin agents. The below picture shows how different agents can be applied for different patients. For example, if there is only one lesion, you can even use it on a finger. You can use it in a foam tray. You can also use it for orthodontic patients or with patients with multiple white spot lesions. Anyone who is interested, this is a very fantastic overall review, a narrative review, not a systematic review, but a very good paper for you to prepare for the exams, which clearly depicts all the different enamel remin systems and their classifications for caries management. Again, this is a type of non-invasive strategy. Now, a special note on hydroxyapatite. Use of non-fluoride toothpaste is gaining, and among them, the hydroxyapatite toothpaste is one of the most favored alternatives to fluoride, which is taking the market of the toothpaste very drastically. So it's a biomimetic material. The function structure is similar to natural enamel and dentine. It's a synthetic hydroxyapatite. It is available as nano-hydroxyapatite for toothpaste formulations. When it comes to mechanism of action, this synthetic hydroxyapatite is able to make a small cluster on the enamel surface. Now, from that cluster, it provides a nidus, and on that nidus, the new hydroxyapatite, the new calcium and phosphate from the saliva can get impregnated, and that's why the remin takes place. So it remineralizes early enamel lesions, it fills surface micro defects, improves the smoothness, and also it is able to help in the reducing sensitivity by occluding the dentinal tubules. Now, in addition to that, if you are writing in exams, you can critically summarize this against the fluoride also. So you can tell the pros and cons of hydroxyapatite with fluorides, like safe if swallowed because it is not having any toxicity effects, no risk of dental fluorosis, effective in remineralization under low salivary flow or acidic pH, and the cons can be that it is not very long time tested, and many of the world organizations like FDA and other organizations have not fully approved the use of complete hydroxyapatite or without fluoride use for anti-caries agents. Now, coming to the micro-invasive strategy, it includes the use of sealants and infiltration. Both these strategies require use of acid etchant, because of which the enamel is abraded at least to the micrometer level. Coming to the dental sealants, there are couple of aspects that you should always write: which teeth, which type of surfaces, which material, and what is the evidence. So it's in general, you can frame your answer. Usually a question comes in essay type. So which teeth, which type of surfaces, which type of sealants, and what is the evidence. This can be the general pattern of various materials that you are trying to explain. As we know that permanent first molars, we have an overwhelming evidence that the first molars, which can be affected by caries more than any other tooth, are right candidate for use of dental sealants. Unfortunately, sealants are very much underused. The capacity of dental sealants to prevent caries and also arrest caries, this specific role of dental sealants is really underused. Sealants are also effective in primary dentition and should be given for high-risk patients. The point that I want to emphasize here, which type of surfaces, we all know that it can be used for sound surfaces to prevent. This specifically for MID, when I'm asking you to use it for non-cavitated carious lesions. So even if you find occlusal surfaces which are non-cavitated in nature, you can use sealants directly sealing the occlusal surface. So systematic reviews have proved that sealants are effective in caries arrest also when applied to non-cavitated carious surfaces. So it is not required for you to go invasive and make class 1, class 2 cavities. When you see a non-cavitated class 1 lesion, even permanent or a primary molar, you can just seal. Seal is the deal, remember. So once you seal it, the same principle we will be using in the Hall technique also. Once we seal it, the bacteria which get embedded become dormant, and then they slowly die off. So not for the cavitated, but yes, for the sound teeth, specifically intended for the prevention, for non-cavitated caries lesion, specifically intending to arrest the progress of the lesions. So which type of sealants? We know that there are different types of sealants, resin-based, glass ionomer-based, and in the resin-based, with etching or without etching. The total etch versus self-etch, that is the important question. Sealants, the best sealants are total etch sealants. So etch and rinse systems are the best systems, but in field setting, GIC-based sealants can also be used with a finger press technique. Below are the few diagrams which clearly shows how sealants are applied, but depending upon the time and the length of the question and the type of question, you can also explain the complete procedure, how it is done. And you can also explain why some sealants, glass ionomer based, are pink in color, because the compliance of the patient, because patient at home can also is able to comprehend, is able to understand if the sealant is retained or not, because we know that the retention of the sealant is the most crucial factor for the success of the sealant. If the sealant is lost, then there is no fun in just thinking or relying on that there is a sealant and it will be able to prevent caries. No. Secondly, if the seal is also broken, then the bacteria which we are thinking that would become dormant. But if the seal gets broken, the nutrients from the saliva can peep in, and then those bacteria will again start to multiply. The caries will also progress. The secondary caries will also form. So it's very important to use a sealant, a composite, in a manner that helps us to make a good seal, because seal is the deal. So you can also quote a couple of papers that occlusal fissure sealing with resin-based sealant can arrest the progression of non-cavitated occlusal dental caries. And then there are papers which also show that proximal sealants are also effective, specifically in preventing and arresting the non-cavitated carious lesions. These are the two papers. If you want, you can take a pic and you can quote these papers, or any other good paper, good systematic review can be quoted for that way. An important micro-invasive strategy, in addition to use of dental sealants, is the use of resin infiltration with the icon. Again, it is a part of micro-invasive strategy. So there are only two things in micro-invasive: sealants and infiltration. There are three steps of infiltration. First is the use of etchant, that is the 15% hydrochloric acid. Second is the alcohol, which is a drying agent, 100% alcohol. Third is the infiltrant, that is the very low viscosity resin only, or you can say very high flowable composite resin. So the steps include etching with 15% hydrochloric acid for 2 minutes. You can remember 2 minutes for Maggie and 2 minutes for etching, specifically in case of resin infiltration. Drying with icon, that is the ethanol. So why we are using ethanol here? Because once we use 15% hydrochloric acid for 2 minutes, it leads to formation of pores within the outer enamel. Now, when we, generally, when we use a composite, we only use a 3-way airway syringe. But because now there are pores which we want these pores also to be dry. So once we use the airway syringe, that the surface will become dry, but not the pores. So to make these pores dry, we use something which has a desiccating property. Now, what better can be ethanol? So ethanol, when it is used for 30 seconds, it goes inside. Within 30 seconds, it dries the surface, it eats up the water, and then desiccates itself. So that's why the pores are now ready for that micro-mechanical retention using the low viscosity infiltrant. So then you apply the infiltrant and light cure it. And this is a very simple example, beautiful example used in the 2 primary incisors with significantly visible white spot lesions, ICDS, 2 score, very clearly visible. And just with the couple of minutes using resin infiltration, you can see how beautiful the results can be achieved. The principle of resin infiltration, specifically in arresting caries, is that infiltrate fills the lesion. So the pores are formed. Now within these pores, the infiltrant goes. This sealed lesion acts as the barrier. So now it is a seal is that in. Now it acts as the barrier. Nothing goes in. So it acts as a barrier to the acids and the fermentable carbohydrates or the different metabolic products. So these infiltrated lesions do not progress in the cariogenic environment. So this is the principle of resin infiltration for arrest of caries. In addition to that, because the refractive index of the infiltrant is equal to the sound enamel structure, that's why there is also homogeneity in the shade. That's why it is also used in making the opacities, the white opacities due to caries or due to other reasons go off. So it also helps in achieving the aesthetics. So indications include white spot lesions because of early caries, proximal lesions, that means enameled, which are as per the IOP or the bite wing X-rays into the depth of enamel, or outer dentine, the post-orthodontic lesions, the lesions of poor oral hygiene, the fluorosis, and other white spot lesions. Not going into the details of the lower, the listed lower ones. The only thing is that we need to understand that resin infiltration is effective for different white spot carious lesions as a micro-invasive strategy, which is the part of the holistic minimal invasive dentistry. So after the non-invasive and micro-invasive, we now shift towards the minimally invasive excavation procedures. So the overall strategies which are shown are minimally invasive dentistry for caries management. Now the third limb is the minimal invasive excavation procedures. Now there are two types of lesions, cavitated lesions and deep cavitated lesions. So cavitated lesions are not very deep, but they are cavitated. They might be involving dentine only to the outer half, but deep cavitated means which are little more closer towards the pulp also. So when it comes to minimally invasive dentistry, minimal invasive excavation for only conventional cavities, conventionally what we do, we make a class 2 cavity. But as a part of minimally invasive excavation, we can use a slot, simple box preparation, we can use a tunnel preparation, and then use a suitable restoration. This is a concept of minimally invasive excavation. Now, another concept of minimally invasive excavation can be ART procedure, which includes the use of excavator, the GMTs, and then followed by the use of a suitable chemically adhesive ionic restoration, that is the glass ionomer, which is the best, or the hybrid glass ionomers. So ART procedure also comes under the minimally excavation procedures, is suitable both for the field settings as well as for the clinical settings. Now, non-restorative caries control, this is the third concept for cavities. Non-restorative caries control, as the term explains, we will not restore the cavity. We will just try to control the caries process progression. So it aims to reinstate the cleansability of cavitated lesions by removing the overhangs. Anything, any enamel or any tooth structure which is leading to more plaque retention, we will just remove that. So biofilm trapping tooth structure will be removed. Subsequently, patients are encouraged to clean the opened cavity and apply fluoride toothpaste. We suspect, or we emphasize, we optimize that particular tooth area would be remineralized use of fluoride toothpaste. The non-restorative caries control is a feasible option to manage cavitated lesions, specifically in uncooperative children and sometimes systemically compromised older adults also. In addition to this, sometimes nowadays SDF is also applied. So when we say SDF, we know that SDF is very commonly used for open cavitated lesions, but sometimes we can also open the lesion and then use the SDF. So both the strategies come under minimally excavation procedures of the holistic chart of the minimally invasive dentistry. So we know that 38% SDF is indicated for arrest of caries. It is cost friendly. It avoids pain. It blackens the tooth, unfortunately. No doubt we have a potassium iodide as an antagonist to blackening, but in most of the clinics, it's still we are using alone SDF. It leads to blackening. So at concentrations of 30% to 38%, SDF shows potential as an alternative treatment for caries arrest in the primary dentition and the permanent first molars. Now again, when you're writing this, you can write what is the material, what teeth are selected, how it is applied, and what is the evidence of that. So these are the 3 or 4 steps that you can follow for the complete chart that we have just made. A mixed method is a Hall technique. Now this Hall technique means directly placing the crown over a cavitated primary tooth. So the important thing is that it is focusing on two things mainly. It combines the biological management of caries lesion. That means we are trying to use seal is a deal approach. We will seal the tooth structure with the help of a crown, so that, and we hope that the bacteria which lay inside would slowly become dormant and may die also. So, and the restorative advantages of preformed metal crown is also there. So this is a mixed method technique, which is called as the Hall technique, specifically used with the usage of stainless steel crowns over primary teeth. Chemomechanical, again a method of minimally excavation. We know that it involves cariosol, peppercary or care. These are the 3 products available. The chemomechanical, so we will use a chemical to dissolute the caries tooth structure. It becomes soften nature, and then you can use the spoon excavator followed by an appropriate ion use forming remineralizable restorative material. So these are the 3 materials. You can go right into detail about the chemomechanical, the peppercary, the cariosol, and the care. So deep caries excavation. So we started with the non-invasive strategy, shifted to micro-invasive, and then the cavitated lesions. In the cavitated, we have just covered the superficial cavitated, which are more closer to the deeper enamel or the outer dentine. So which involved minimal excavation cavities, ART, Hall technique, and mixed methods technique. So in the deep caries, conventionally we have been taught to excavate till the deeper levels to reach the sound dentine. Of course, this is an older concept. Then we shifted towards excavating to only the infected dentine, leaving the affected dentine as such. But nowadays, we have again shifted, again become more conservative, and we say it's not even necessary to excavate the complete infected dentine. You can even leave that. This paradigm shift is the main principle of the minimal invasive dentistry, specifically in relation to deep caries excavation. So this is the chart which you can understand. So conventionally, we had been making, I'm not saying we have been, we had been making box cavities, that is a non-selective caries removal. We don't think what is infected caries, but infected caries, we just remove the complete caries, rather we tend to reach the sound dentine. This was required in the era of amalgam. Now amalgam is going off. Selective caries removal following indirect pulp treatment, when we say that remove only the infected, leave some affected. But now the more conservative approaches which have partial caries removal, which includes stepwise caries excavation, 1 step, and ultra conservative approaches. What is the meaning of stepwise, which is the most frequently used? That we will be excavating only 1 section of the infected dentine, leaving everything as such, and on the second visit we will reopen, re-enter the cavity, and then in that period we assume, because after excavating we have used some material like calcium hydroxide or MTA, assuming that remineralization will take place, then we find the dentine which was left becomes remineralized, is harder in nature, which is amenable to be restored permanently. In 1 step partial caries excavation, we just remove some part and restore it for the good. Now, everything is based on only on the 1 principle, seal is the deal. All these strategies are based on only on 1 principle, seal is the deal. If you are not able to use the restorative composites in a manner that provides appropriate seal, do remember your restorative strategy is going to fail. Because it's important that there should not be any percolation, because the bacteria which will be remaining behind should not be able to get any of the nutrition That's why seal is the deal. Now the question, the last slide that I want to show you, how you choose a restorative cement. Of course, this will be covered in some other lecture, but just to give you an overview, that these are the 4 different types of material that we use. Silver amalgam on one end, composite resins on the other, glass ionomers, and then the smart composites. Now, glass ionomer can be conventional GIC or some kind of hybrid GIC or resin modified GIC, which is also sometimes called as light curable GIC. Then composite resins can be flowable, packable, self-adhesive resin. Smart composites includes the usage of a glass ionomer and composite resins in some form, that it can be called as compomers, geomers, ionomers, or muscles. Remember, a remineralizing agent is one which is ionic in nature, which is able to release ions, which has a glass component in it. Composites do not remineralize but have strength. So glass ionomers are able to remineralize but not have strength. So that's why the combinations of these are frequently being used to have both the advantages of remineralization and strength. That's why different researches have led to different materials, and these type of materials should be used. Now in composites, apart from this classification, you should also be understanding what generation, like it is self-etching, total etch. Now self-etching can be 2-bottle system, 1-bottle system. So which of the material you are using, if it is not able to provide appropriate seal, it will not be functional, it will not be usable. If you are excavating only half of the dentine, infected dentine, you want your bond to be formed with the infected dentine. So that's why all those concepts should be very much clear to you, specifically in the clinical scenario. So there is a hybrid material which is called as Centionine, and there is a hybrid of amalgam and glass, which is called as Cermet and Miracle. So these are the materials, you know, which we frequently use in the pediatric dentistry. So whatever you do, aim to achieve the seal, because seal is the deal. So take home message from my side is that caries is not a synonym of cavity, but it is a process. It constitutes both early non-cavitated and the cavitated lesions. Management of caries should not only include the prevention or simply the restoration. The aim should be to control the process. We do not want patients coming again and again with newer lesions. So principles of minimal invasive dentistry can help us to control the disease. For early lesions, use non or micro-invasive methods, like we have discussed in that chart. Non-invasive includes biofilm control, dietary control, and mineral control. Micro-invasive includes sealants and infiltration. For cavitated lesions, classify, first of all, divide into 2, carious lesions and deep cavitated lesions. Use NRCC approach, Hall technique, stepwise, depending upon the depth of the lesion. So with this, I wish very successful exams and a very successful career ahead for all the postgrads. I once again convey my thanks to the chairpersons. I also convey my thanks again to Dr. Madhu and his team and all the ISPPD office bearers for giving me this opportunity on this topic of minimal invasive dentistry. Best wishes, best of luck. Thanks a lot. Thank you.
Thank you so much, sir, for this such a clear and concise lecture, which is going to benefit our students tremendously. A lot of thanks to you. And I request to present the certificate, sir, now.
Dr. Neeraj, there are plenty of questions on the platform. May we request Dr. Neeraj to either type
Okay.
I have already typed.
Yeah, I
Thank
could
you for
see that
giving
you're
me this
typing in
opportunity.
between.
Sir, I have already typed. I think there were about 25 questions. So I think 5 are remaining. So I'll try to type that also during this only. I have typed almost, I've answered 14. I think 4 are remaining. I'll type that also.
Yeah. And Dr. Neeraj, if you have any material, like any reading material for them, maybe you can attach there.
I have, I'm just opening the chat. And in the chat, I'm okay. I'll just send a couple of articles in the chat.
Yeah. And
then
even
you can share it with
email me the reading material. We have created a group on Telegram. I'll share that reading material in that group.
That's perfect. I will definitely do that.
Thank you.
Thank you.
Thank you.
Thank you once again, Dr. Madhu, Dr. Neeraj, Dr. Virender Goyal, sir, for giving me this opportunity. And thank you to everyone, all the participants. And I'll definitely post all the articles which are required for a student to answer the questions. No problem. And in future also, if they have any concerns about this topic, I'll be happy to help them. No problem, sir.
So we present the certificate to sir.
Thank you. Thank you so much.
Thank you, sir.
Thank you, Dr. Neeraj, sir. It was a very informative presentation. Now we'll go to the next session. It's my privilege to introduce the next speaker of the day, Dr. Priya Nagar. She is presently working as professor and head of the Department of Pediatric and Preventive Dentistry, Coorg Institute of Dental Sciences, Virajpet, and she was professor and head of the department at Krishnadevaraya College of Dental Sciences, Bangalore from 2015 to 2025. She completed her BDS and MDS both from JSS Dental College and Hospital, Mysore, with more than 20 years in academics in pediatric and preventive dentistry at various roles and responsibilities with more than 50 research publications in national and international journals. She leads UG and PG training, clinical services and research in pediatric dentistry. Under her leadership, her department has consistently ranked among the top performers in academic results and research output in the institution and university. She specializes in pediatric dentistry, pediatric orthodontics, and pediatric psychology. Her focus areas include preventive and interceptive orthodontics in children, behavioral management in pediatric dentistry patients, curriculum design and teaching methodology for dental education, holistic development of children's oral and mental health habits. Over to Dr. Priya Nagar for a presentation. Dr. Dev, if you can project the presentation. Mr. Dev.
Yes, sir, I can share.
Present here. I, Dr. Priya Nagar, Professor and Head of Department, Coorg Institute of Dental Sciences, Virajpet, have been given an opportunity to present a topic, Epidemiology of Dental Caries and ECC amongst all of you. Let me take a moment to thank the organizing team of Rapid Review 2025, Dr. Madhu and his brilliant team, and all the office bearers of ISPPD who have been so keen and so prompt in this venture of theirs of rapid review, which helps the exam going students immensely. Let me get ahead with my topic. I would like to start my topic with the type of questions usually asked around this topic. They are mostly very, very straightforward. They would ask about the epidemiology of a particular global region, which I will be describing in the further slides, or generally about the Indian scenario over the past and to the present. Let's start with the topic itself, dental caries. What's the current concept in the pathogenesis of dental caries? We all know about it, that the whole matter is about the pH decrease. So there is a demineralization and remineralization cycle which is going on continuously in our oral environment. So whenever there is a decrease in pH from the normal pH, that is 5.5, the demineralization starts. When I say what is demineralization, there is, because there is a unsaturated salivary component there, so
there is an unstable hypophosphatate ion which comes out. So all the ions from the enamel try to leach out and saturate the salivary component or the oral environment. So this is called as demineralization for the enamel. And whenever the neutral pH is achieved, or the pH comes back to normal, these ions only, the other ions which are present in the oral environment, tend to go back. And so basically what I'm trying to show on the right hand side is carbonated hydroxyacetyl crystal, when it gets demineralized because of the acid produced in the plaque or in the oral environment per se, we have partly dissolved crystals. These crystals are, in the beginning, they are the incipient lesions, the white enamel lesions, what we call. And because there are other minerals present in the oral environment, for example, fluoride, this fluoride or other calcium or phosphate go back and remineralize the enamel, and we call that process as remineralization, and fluoroapatite-like crystal can be formed, or a coating of remineralized crystal is formed. So this is what is described by Gordon Nikiforuk in his book, Understanding Dental Caries, Etiology and Mechanism, and you guys can go through in detail. But this is the basics of development of caries. If the remineralization proceeds, then we don't have any issues. But if the demineralization continues because of whatever reason in the sense, because of the longer time of pH decrease, because of the retention of the food, the pH is lower for a longer time, and that longer time or multiple issues of pH decrease. So either of many of the factors, or you have hypomineralized enamel, which is anyways more susceptible, and those situations where you have lower spikes of pH, then you can have that. So this is the basics of the remineralization, demineralization. Coming to the biological mechanism of ECC, again, I've tried to show that saliva has antibacterial property, GCF has antibacterial properties, and many remineralizing agents are present in the oral environment, which can precede this demineralization, which is happening because of the acids and the combination, because of the fermentable carbohydrates and the karyogenic bacteria, a combination which causes the caries onto the tooth surface. Enamel hypoplasia can accentuate the whole process and cause the ECC or the normal caries. Caries outcome focused model that aims to maintain health and tooth structure using a personalized risk-based management given by International Caries Detection and Assessment Format and published by PITS in 2018. It speaks about 4 Ds of caries management. So they say first you have to determine. So determine the risk level of the patient, then detect the caries and access them, decide what staging they are in, and decide what is the caries plan for them. That is, if you want to go for the preventive or you want to go for the restorative one, then you do. And then risk-based recall interval is there between 2 and determine. Going on to another model, this model is given by Tinoff and was published in 2019. This model is speaking about the domains. So it speaks about the first domain is the knowledge base, where we should have the knowledge about the etiology and the pathogenesis of ECC and worldwide prevalence of ECC. This helps us make an understanding that the area where I am working in, what kind of patients I would be seeing more. Maybe I can be equipped attention seeking, and I can be I can be more prompt in my decisive factors, or I can look into those factors. The second domain is, as we had spoken the last slide, risk assessment and diagnosis and synthesis. Domain 3 is the clinical decision-making domain, where we have one side we have preventive management and non-invasive management, and the other domain is domain 4, which is the restorative management and the preventive care. So it is the decision of the clinician whether we would like to go for the preventive management or the restorative management. Going on to domain 5, that is the clinical and the public health practice, which is my topic, where we can help in making the changes in the health policy, or help in developing community programs, or using these criteria in future for developing further and better studies. And we can check the impact of these caries, especially ECC, on the oral health ratio rate of quality of life. WHO has always been very clear about on the public health intervention against the ECC in 2016. They spoke about 3 types of care: primary care, secondary care, and tertiary care. Primary care, they call it the prevention care, where we have to use fluoride exposure, oral hygiene index, diet counseling. And in secondary care, we use pharmaceuticals like, again, topical fluorides, give them as the loosely bound fluorides in the form of toothpaste or application of SDF. And the tertiary care, we limit the extent of the lesion and do the surgical intervention, that is restoration or extraction. They have described the first visit as to identify the causative factor and take the saliva sample. Detailed history should be taken. Parental counseling should be done. Diary should be recorded. Total emergency or the relief of the pain should be done. Record plaque and gingival indices. Oral hygiene instructions and x-rays should be taken. And topical antimicrobials like chlorhexidine can be recommended or applied. On the second visit, which follows in 1 week, you analyze the diet chart or do the counseling. You repeat the plaque and gingival indices, perform Caries activity test. On the third visit, which is the second, after 2 weeks from the first visit or 1 week from the second visit, you do permanent restoration, bulk therapies, crowns, and extraction and space maintainer. There has been a description by Anil and Anand in 2017, who state the strategies for prevention of early childhood caries at various levels. We have home care, professional care, and community care, where home care includes dietary habits, oral hygiene, fluoride, supplements, and transmission of bacteria. Professional care is the diagnosis part, diet counseling, fluoride application, and pit and fissure sealants. Community part is the health education, community development, and water fluoridation or school health policies, etc. Early diagnosis, whether it is in the clinical setup or at the community level, has been the main criteria for by WHO. It is a clinical criteria for an oral health professional, dentist, dental therapist, nurse, or dental hygienist. It is to able to diagnose ECC or caries as per WHO. In addition, suspicious white spot lesions that may indicate early progress of the caries in teeth should be detected carefully. Primary care teams, if trained appropriately, can also detect early caries lesions. A mouth mirror and satisfactory lighting is sufficient in a community setup, is as said by WHO. But they give emphasis on the early detection of the carious lesion, and that is the prime most important thing in management of ECC. And they say that integrate oral health checkups into the primary care or the community level so that many or most benefit in your community or in your country. Now here I present by PITS and published in 2018, something called as Caries puzzle. Now this puzzle shows us 2 actions for the health professionals and for public patients and others. They speak about the nutrition, the control of the sugar, and they speak about the education and behavior change of a patient. They speak about cariology, that is implementation of fluoride as in the loosely bound fluoride with toothpaste or mouthwashes, or topical fluoride by the professional. They speak about the public health upstream policies should be initiated in the community level. Clinical practice or Caries Care International 4T. That is Caries Care can be included in the clinical practice with the 4 Ds which I had discussed earlier. ICCMS, Caries management, that is education, research and dental public health policies should be integrated. You can understand that I am very much emphasizing on the public health policies because that is the topic for myself. Let's go on to epidemiology. The term epidemiology is derived from the Greek word epidemic. Epi means among, upon means demo, upon, or demos means study population or people, and logos means scientific study. So it is the scientific study of the disease pattern. Introducing epidemiology, the term epidemiology is derived from the Greek word epidemic. Epi means among, upon, demos means study population or people, and logos means scientific study. So it is the scientific study of the disease pattern in any population. In broad sense, it is the study of effects of multiple factors on human health. Is epidemiology, the science of mass phenomena of infectious diseases or natural history of infectious diseases, as said by Frost 27. The study of distribution and determinants of health-related states or events in specified populations and application of the study to the control of health problems, as said by John M. 88. Basically, we have to search for knowledge about that disease because that is what is going to help us develop proper and able attentions or treatment outcomes for the disease, and we can apply that in any health service. According to International Epidemiological Association, the aims and objectives of epidemiology, going to the aims, to describe the distribution and magnitude of the health disease problems, to identify etiological, that is the risk factors, to provide data essential to planning, implementation, and evaluation of these services for the prevention, control, and treatment of disease, and setting priorities among those in services. Now, it is to eliminate or reduce the health problems of the community, to promote the health and well-being of the society as a whole. Sarakai said that in 2016, and his publication states that. Functions of epidemiology is to discover the agent, host, and environmental factors, determine the relative importance of the causes of the illness, disability, and death, identify those sections of population which have the greatest risk, and we can apply the preventive measures, the other measures for preventing those or implementing for helping those, to evaluate the effectiveness of these preventive and therapeutic health programs which were planned, and to assess whether they are working or not. So as I said, 3 Ds of epidemiology are disease frequency, distribution, and determinants. Health status of the population can be understood by epidemiology only. It is often used to describe the health status of the population. You can see whether how many people have good health or they have ill health. You can have the knowledge of the disease burden in the population, which is essential for the health authorities to plan or to see whether their prior plans are working. They should be discarded, and newer plans or newer policies should be made. To use limited resource to the best possible effect by identifying the priority health programs for prevention and for care. And you can evaluate your intervention. Suppose you have come up with an intervention, you have a treatment medical care, you can see whether it is helping in developing the good health or it is not helping. The ill health is converting into good health or not. Through health promotion, preventive measures, public health services, you can see the effectiveness and efficacy of these health services. Means determining things such as impact of, for example, any of the contraceptives used on population control, or our, let's say we introduced a fluoride regime for all, and then we can see the control. Applications of epidemiology in public health: preventing disease and promoting health, community health assessment, improving diagnosis, treatment and prognosis, evaluating health interventions and programs. So basically, applying epidemiological principles and methods to the problems encountered in the practice of medicine has led to the development of something called as clinical epidemiology. We can understand the Disease frequency, that is what I spoke about in 3D, refers to the measurement of the health-related event in form of rates and ratios. Let me explain that. Rate is, for example, number of deaths per 10,000 population in 1 year. Proportion is number of deaths in specific population. Ratio is number of male deaths to female deaths. Now, incidence calculation is number of cases in the defined population divided by total number of population at risk by 10 into n. And same is the incidence rate, that is number of cases in the defined population by total number of at risk over a specific period of time into 100. We have something called as prevalent rate, which is divided into 2 point prevalence, that is at that specific point, and period prevalence in that particular period, which is a specified period of time. Incidence rate, like prevalence, is again into cumulative incidence. At risk at the beginning of the interval, you specify how many patients are there or the number of new cases are developed. After that particular point, how many are developed. Incidence density is number of new cases occurring over a specified period again. Now, where do we use them? They are used for acutely acquired diseases. Prevalence is used for permanent states, conditions, and it tells us about the ill health. Likewise, incidence always requires a duration. Prevalence may or may not. In a steady state, that is, if incidence is not changing, the population is stable. Prevalence rate is equal to incidence rate during the duration of the time. This diagram always describes, so we have incidence and prevalence. Number of cases at a time period over the number of people at risk, could be flooding or could be trickling. Water in the tub is the burden of the disease. All people who are affected, percentage of the people who have the disease are this one. The cured ones are this, through your methods. Pattern refers to the occurrence of health-related events by time, place, and person. Now, regarding time, it could be an annual occurrence or seasonal occurrence or daily occurrence during epidemic, hourly occurrence during an epidemic. Place is geographical variation, urban-rural differences, location of the houses and schools. Personal is dependent upon age, race, gender, marital status, lifestyle behaviors, occupation, environmental exposures. The 5 W's of epidemiological studies are what, that is the clinical, who, which person, where is the place, when is the time. This is descriptive epidemiology. Why and how, that is the risk factors and mode of transmission, are analytical epidemiology. But today, I'm going to discuss about descriptive epidemiology. I'll let you know why I'm discussing about that. So descriptive epidemiology are the observational studies, and they have a nature of its own course. So we have assessment, so we have assurance, and in that we have the assured component of the workforce. We evaluate, we link, we provide, then we assess if our policies are working, and then we develop our policies. We check again and we see in case if our policies which were formulated are working or not. We need some extra intervention, or we need, they are fine and we can continue with them. In descriptive epidemiology, it is concerned with observing the distribution of the disease in human population and identifying the characteristics with which the disease seems to be associated. Now, the procedure is you define the population first, you define the disease. Under this, you check the time, place, and person. You describe the disease by time, place, and person. You measure the disease, compare with known indices, formulation of an etiologic hypothesis. Step 1 is defining the population. You will see which population you should decide, and you can divide it into according to age, gender, and occupation. Then you have the epidemiologist define the disease. In step 2 is which can be measured and identified in the defined population with a degree of accuracy. This is different from the clinician's definition of a disease. Step 3 is describing the disease. You describe the time, which time you should, because at that time the disease is occurring. And the place, which climatic zone, geographical, and person according to gender, marital status, or any particular section of community, or caste, or height, weight, blood pressure, etc., etc. Place distribution also is there. You can choose from rural, urban, or local distribution. Or person distribution is depending upon which age, which gender, if any marital status is included, or any occupation. It can be social class, as I said, a particular community which is affected more, or certain types of behavioral patterns in a patient, and then they can be selected. Or stress can be a factor as well. Step 4, you measure the disease. Mortality can be measured as crude rates or specific rates. Morbidity measured in terms of incidence rates and prevalence rates. Then you compare with the known indices and you check. This can be the first time analysis, or you can check and evaluate that over this time whether your previous policies have worked or not. And then you come on to the hypothesis according to the population or specific causes, expected outcomes, dose response relationship has happened, time response relationship has happened. Now, I will come to my topic proper, which is the scenarios, the global scenario of dental caries over these many years. Caries is a highly prevalent chronic disease and poses substantial burden on global health and well-being. Understanding its temporal trends, geographical variations, and disease burden in terms of incidence, prevalence, and disability-adjusted life years, that is called as DALYS. Please remember that. I will be using that in my slides further, is critical for informing public health policies and interventions and aimed at mitigating its impact, whether they are working or not. Previous research, such as global burden of oral disease studies, has underscored the significant contribution of dental caries to overall health burden worldwide. However, a comprehensive and updated analysis encompassing recent data spanning over the last 3 decades is almost lacking, which limits our understanding to the evolving caries landscape and hinders the development of effective strategies to address this pressing health issue. Existing studies, they are very good. They lack detailed temporal trend analysis, geographical comparisons at fine resolutions, and in-depth explorations of the drivers behind observed patterns. Further, oral diseases including caries has been increasingly recognized as integral to overall health and well-being because they've been related to these diseases like cardiovascular diseases, diabetes, respiratory. So, understanding the burden of the dental caries has become a very important point or a matter of concern for the global community to correlate it to other diseases and to help in its prevention. This is a very good article. Now, the thing is that over 1990s is when WHO started discussing about the caries burden and started working on whether each country has been doing enough for preventing their people from dental caries. But that time, it was so difficult to collaborate all the countries and come up with the same plan with all the countries. Why? Because each country is divided into developing, developed, or underdeveloped. You cannot have same policies for all countries. So, to make sure that even the underdeveloped countries were doing as much as they can, or probably the best. To analyze their situations, WHO at that time had come up with areas. I'll be discussing them in further slides because I want your interest to develop. I know this topic is a little dry, but I really want to tell you that this article by Xiong Li, published in BMC Oral Health 2025, has done, which was, I don't know, which would have made my task so difficult, but this article, which I found, is a work of art according to me, because this person, this team, has analyzed the global, regional, and national caries of permanent teeth, incidence, prevalence, and disability adjusted life years in 1990 to 2021. Why this is important is because this can be a teaching curve for all of you, how we can do the meta-analysis and how we should be interested in doing. That is why I've taken up this article. So this, although it is about the permanent teeth, in 1990 to 2021, what was the analysis for the global burden of the disease study? Now here, as you can see, his table 1 states the global count of the prevalent cases, age standardized prevalence, and percentage change in count of prevalent cases, and age standardized prevalence over 1990 to 2021 for all the oral conditions. He divides the conditions into untreated caries, carious deciduous teeth, untreated caries of permanent teeth, severe periodontitis, edentulism, other oral diseases, main oral conditions, lip and oral cavity cancer, orofacial clefts. Here on the table 2, he has about, as I said, daily altered life, disability altered life years. He has described into the same disease descriptions. Now, I don't know how much effort it would have taken. I would like to appreciate it. Why? Because he has given us the prevalent cases and the percentage change in both the tables, which is probably very, very invaluable. And this shows us that how they, it is important to evaluate your policies, whether your actual policies are working at not only the community level, but at the regular clinical setup, or at the regular level as well. Now I would like to make you understand what he speaks about untreated caries and deciduous teeth. The global counts of prevalent cases remained unchanged between 1990 to 2021. 30 years with a percentage change of about 6.50%. We haven't done much. We think we have developed. We are developing all sorts of diagnostic procedures. We have everything, but there hasn't been a much change globally, I'm telling. In 2021, the global age standardized prevalence was 7,550 per 100,000 population. Increasing trends in prevalent cases were observed in African, Eastern, Mediterranean areas. Decreasing trends were seen in European and Western Pacific regions. No changes in the region of Americas and Southeast Asia region. No differences in global counts and rates were found between both the genders. Untreated caries of the permanent teeth, again, the global count of the prevalent cases was increased by 53% between 1990 to 2021. No difference in the global counts and rates were found between the genders. Increasing trends were seen with the African region having the largest percentage change in the prevalent cases, and European region having the smallest percentage change in prevalent cases. In 21, Southeast Asian region had the highest count of prevalent cases, and the Eastern Mediterranean region had the lowest counts. Now he has, how could he come to that conclusion with the areas, you would say, those same untreated caries of deciduous teeth, permanent teeth, severe periodontitis, edentulism, he has divided into various regions, that is African, Eastern Mediterranean, European, etc., etc. It's a very good read. Please go ahead and see about it. Again, this one is about the edentulism, other oral diseases. Facial clefts are also described. Now, if I have to summarize, summarizing the whole paper, they say that decrease in the rates of oral condition need to surpass rates of population growth and aging to stabilize or even decrease the burden of caries on the health system. Although overall changes in the prevalence and burden for 1990 to 21 were relatively smaller, either upward or downward, it is important to highlight these trends. Most striking finding was the decline in rates of untreated dental caries and edentulism. However, the concern point is that the reduction observed in the global age standardized rate of these oral conditions has not balanced the increase in the prevalent cases and the disability ratio driven by expansions in the population size. So it is not according to the population. The population is increasing, but the rates are staying static. An encouraging finding was the decreasing trends in the disability rates for orofacial clefts. despite the increasing trends in the prevalent cases. The situation for severe periodontitis with increasing counts and staggered rates is worrying, as that of lip and oral cavity cancers and increasing counts and prevalence of the static disability counts over the time. African Eastern Mediterranean regions were behind others. They showed increase in untreated caries. So basically, if we have to talk about the global trends, yes, of course, there is a very visible trend shown, the developing countries and the developed countries, and the policies have to be developed, maybe by WHO or by the particular countries, and the intervention is required. Distribution of dental caries according to WHO. Now, I was talking to you about 1990s. WHO at that time used to emphasize on using DMFT as the index and had divided the countries for ease of understanding and analysis and comparison into various regions. Like African region, AFR, had 46 countries, and their data was ranging from 1977 to 2004, and they had shown an average of 1.7. This is the area which was shown, and here Tango and Tanzania already had 82% of the prevalence rate, which was lower than the regional average, and the index had 1.3. The next one was the regions of the Americas, AMRO, and they had the data from 1987 to 2008, and DMFT was 2.1. The area SEARO, the average years of the studies was 1999, and the DMFT score showed average 1.95. At that time, in 2003 or something, I remember the DMFT aim or the global reach was told DMFT 2 for all the countries. So if I'm saying 1.95, they were almost practically there. Next was the Euro region, and we have the studies from 1973 to 2008, and the DMFT was 2.3. The index ranged from 0.7 to 7.8 as well, but so certain countries were on the higher level. Going on to the Eastern Mediterranean, EMRO, we have studies from 1998, and they were on 2. Next region was Western Pacific region, WPRO. The DMFT was shown as 1.93. Half of these countries had an index of 1.75. DMFT values range from 1 to 5. So that is how they used to analyze if the countries are doing enough or they have to press on certain policies to be implemented by the countries. Now, the most important thing, dental caries, Indian scenario. Discussing about the dental caries Indian scenario. Now, presently, WHO on their website presents the profile of each country like this. I have taken for India, and you can see they have given the total population in thousands, and as per 2020 data, and per capita current health expenditure in PPP, that is in INR and dollars. Now they describe various things, and I will be describing them in further slides, but this is how you can check any country on WHO website. They speak about oral disease burden and divided into prevalence of oral diseases, estimated prevalence of untreated caries of deciduous teeth in children 1 to 9. India had 43.3. Prevalence of untreated caries of permanent teeth with children more than 5, 28.8. Prevalence of severe periodontal disease in 15 plus, India was 21.8. And prevalence of edentalism in 20 plus years is 4. Then you have lip and oral cavity cancer, and India for female, it was this, male, it was 104,661. Like that, it was there was an incidence rate which was given 4.6 and 14.8 for female and male. Risk factors of the diseases were also per capita availability of sugar in the market. If the data was not there, so they have put a dash, and prevalence of current tobacco use for 50 15 plus years is also given 13.7 in female, and male it is 42.4. Per capita alcohol consumption for female 1.9 and 9.1. Economic impact is also described. Total expenditure of healthcare in dollars 64. Per capita expenditure on dental healthcare setup by the country is 0.05. Total productivity losses due to 5 oral decision in millions is 7249. Fluoride toothpaste data may be not available. What I'm trying to show is that a lot of work needs to be done, and all of us, yes, of course, we love to, think about our finances and work for ourselves. But when it comes to country and we have to work for the community level, we have a lot to think about. They have given a national health system response also. If the policies, implementation of tax on sugar sweetened beverages, yes. Existence of national oral health policies and strategies, India has, yes. Presence of dedicated staff for oral health working on NCDs at the MOH level, yes. So they have done a detailed about the assistants and therapists. We have 0 prosthetic technicians, we have 0, and in dentist, the ratio is 2 per 100,000 population. Likewise, availability of procedures for detecting, managing, and treating oral diseases, oral health screening. Yes, we have available urgent treatment, available basic restorative procedures, available. Likewise, oral health interventions as part of health benefit packages, which are given on the community level. We have 30% of the population covered of the largest government health funding schemes. Another excellent article by Abhishek Mehta from Jamia Millia Islamia. He speaks about the economic liberalization, which was started 25 years back in India and has led to rising gross domestic product and per capita income, and has declined the poverty. There has been an improvement in various health status indicators in the Indian population. As oral health integral part of general health, a retrospective study was designed to assess the effect of economic liberalization on dental caries experience from 1992 to 2016. He collected all the data and he has concluded. Now, he says India is a developing mixed economy with 1.3 billion population, initiated economic liberalization in 91. Before that, growth rate was 3 to 4, but currently it is one of the largest growing, 5th largest economies in the world. Total expenditure on healthcare as population is still 4.7%. India declared polio-free in 2015. Dentist population ratio 1 to 10,000 to 271 people. But there is a disparity between urban and rural centers. Last National Oral Health Survey was conducted in 2002, 2003, published in 2004, and DMFT index score for Indian children was around 2. And caries prevalence was increasing with age, 51.9% to 61.1% from 5 to 15 respectively. But after 2005, WHO had given a score of 0. His tables show the studies which are included and the trends in caries prevalence from 92 to 96, you can see, and from 2012 to 16, we haven't come very far, let me be very honest. And if I speak about DMFT scores, 2.9 to 1.9 in 2007 to 2011, back to 2.3, probably on the community level or on the overall level, we are not working very hard. The community is not improving. Again, if I divide into 2 to 5 years, 6 to 10 years, 11 to 15 years, and over the years, he has done the analysis. So you can very well see that the DMFT hasn't much. We have a lot of data which is missing. One thing is that. And the second thing is that not much has changed. And he described about North, East, West, South, which is 50.4, and East has 48.9. But moreover, we are in that, and DMFT is also 1.9. We are far away from our score of 0. We are not even below 2. There was a decline in caries prevalence in the youngest and oldest age group, whereas middle age group 6 to 10 years showed an upward trend. Now, these figures are quite similar to those reported by WHO or TCI, Morera R. and Kundu et al. For Indian children. Caries prevalence was found less in northern and eastern part of India compared to the southern and western part, but Kundu et al. Were contradicting that. India, being a developing country, has less caries experience in comparison to other developing countries. High SIC values suggest a skewed distribution of the dental caries in Indian children. In India, there is a nationwide comprehensive disease surveillance in place. Hence, recent epidemiological data are not available to make a strong case about the oral disease burden. Thus, the indicators commonly used to assess oral health status do not provide clear and easily available data in Indian scenario. This is a beautiful article by Prashant Narang and Ashok Doble and others. And this describes the India's oral health and challenges economic impact, need for the preventive strategies. I found this article very, very intriguing, published in 2025 recently. Again, the prevalence of oral health conditions is alarmingly high, driven by multifactorial. While 68.84% of the population lives in rural areas, the majority of the professionals want to work in the urban areas. Despite efforts by organizations like IDA to meet public needs, the current infrastructure and manpower within the primary healthcare services is falling short. The dental workforce in India predominantly focuses on treatment and emergency services with limited attention to preventive dentistry. Consecutively, untreated oral health conditions are worser over time, necessitating professional intervention at advanced stages. This delay not only increases the treatment cost and imposes a burden onto the country, and economic burden is on individuals and workforce. People lose productive work days, which finally affects the productivity of the country as well. And that is why they have started describing DALYs, the disability, that those are the days when people are not available for work. Coming on to the expenditure of oral health care in 2019, WHO highlighted the significant economic impact of oral diseases in India. The cost associated with treatment and prevention of these diseases posed a substantial financial burden on the country. Economic impact included both direct treatment costs and indirect costs, such as loss of productivity days of the workforce, and total economic burden was reported 613.2 billion, which is USD 7.3 billion. In contrast, preventive oral care is remarkably cost-effective, requiring only 10 rupees in INR per person annually. These findings highlight the economic rationale for scaling up the prevention-focused strategies. India has implemented some initiatives to promote child health, such as Rashtriya Bal Swasthya Cariogram, which addresses various pediatric health concerns. However, dedicated national programs focusing specifically on pediatric dental care remain scarce. Strengthening school-based oral health programs and integrating dental services into primary health care would significantly improve outcomes. Fostering preventive care and early interventions can reduce the long-term burden of dental disease and promote lifelong oral health. India's oral budget is inadequate. 2013 and 14, Indian government allocated only 2.2% of its 16.65 trillion INR budget to the Ministry of Health and Family Welfare, with no specific funds embarked on oral health. 2023, the budget was increased to 45 trillion INR with the Ministry of Health and Family Welfare receiving 2%. Of this, only 240 million was designated to oral health under pilot schemes, equating to a per capita expenditure of 5.4 INR. Building a substantial healthcare framework is the need of the hour. Incorporating oral health insurance into national health plans significantly reduce out-of-pocket expenses and minimize productivity losses. And although national level schemes like Pradhan Mantri Jan Arogya Yojana, Rashtriya Swasthya Bima Yojana provide healthcare coverage, they currently do not include oral health services. Developing a public-private partnership model would enhance access and coverage by leveraging existing healthcare infrastructure. Now, this proudly I would like to present the National Oral Health Survey, because the young periodontists would not even know about it. But yes, my seniors would have participated in it, contributed in it, and this was published by Dental Council of India 2002. This is the National Oral Health Survey and fluoride mapping, which was done for India. And you can see how it is supposed to be done. Now, let's say we all get together, we have to do such efforts. It will take how much of effort it would have taken to divide it among 5 years, 12 years, 15, 35, and 65 and above. Oral diseases, mean teeth present in the mouth, dental caries with the prevalence, SIC index, and DMFT, periodontal diseases, loss of attachment, malocclusion, fluorosis, all these need to be done. And then there was a distribution on the oral health conditions. And this was again distributed into age-wise. Now, this one was again as I stated, these tables were extensive and they had so much data with the age distribution. And now you're going to be surprised as how they had divided it into the states, that is Andhra Pradesh, Assam, Gujarat, Haryana, Himachal Pradesh, Jammu Kashmir, and others, including Karnataka, Kerala, MP, Maharashtra, and into the years with the mean number of teeth present, DMFT, all those were given into this. It was an extensive work that was done, which after 2004, I think we have not dared to do that. Now, probably it's time so that we can analyze our oral health burden. Similar was done for the malocclusion, and you can see again fluorosis, and with fluorosis and describing the fluorosis into the classification into the various union territories. The data was collected from everywhere and was compiled and analyzed. Again, 12 years, the same things with enamel defects, opacities and hyperplasia was done. Now, if I have to concise it, 5-year-old, 37.9% had caries in 25% of the teeth, including 10.1% with caries in 25 to 50% of the teeth. More than 48% of the affected children had caries, less than 50% of the teeth. Caries prevalence ranged from most states like 40 to 60%, lowest in Delhi and Rajasthan, highest in Goa, high prevalence in Assam. 12 to 15 years old, vast majority had caries less than equal to 25% of the teeth. Remainder had up to 50% of the teeth affected. Caries prevalence across the states, highest in Punjab, lowest in Rajasthan. Mean DMFT was 1 to 3 in most of the states, and for 15 years it was 2 to 4. Now, if I have to specifically describe the epidemiology of early childhood caries, this is another article which is beautifully given by Mayer and published in 2018, Early Childhood Caries Epidemiology. In this, I took the epidemiology part, and he speaks about ECC is still one of the most abundant diseases worldwide. And he speaks about that the ECC incidence is 1.7 billion. As described by WAS in 2016. And recent data, for example, from Australia, it shows a prevalence of more than 50% of 6-year-old children. And data from different parts of the world showed 89.2% of the children with ECC in Qatar, 36% in Greece, almost same prevalence, that is 40%, reported in USA among 2 to 11-year-old children. Recently published study from Germany shows 10% of 3-year-old children with ECC and an increase up to 50% in 6 to 7-year-old children, as said by Bassner et al., 2018. Data from 44 WHO member states countries, it was reported that ECC prevalence ranges from 0% in Nigeria to 98% in Cambodia and Bosnia. In Asia, especially in Far East region, the prevalence of the disease in 3-year-old ranges from 36% to 85%. The prevalence in India has been reported in the ranges of 44 to 49% among 8 to 48-month-old children, as described by Fantuma with P et al. 2018. One more article, Prevalence of Early Childhood Caries in India, a systematic review and meta-analysis by Indra and published in 2022. There is this table with division of the number of studies taken and the pooled prevalence described. The overall prevalence of ECC estimated from 71 studies was 69,330 participants. It was 46.9%. Males had a higher proportion of ECC, 47%, females 43.8%, but I would consider insignificant. Regional analysis showed highest number of studies conducted in southern India with a pooled prevalence of 44.6%. Central India has the least number of studies but reported highest pooled prevalence of 62.3 compared to northern India, which had pooled prevalence of 51.6. Eastern and western India pooled prevalence of 50.4. Why we are studying epidemiology? Because this is the need for the hour. No authentic, reliable, or consolidated data on the magnitude of oral health problems, behavioral practices of people, or for preventive and curative care, dental manpower, infrastructure, and on the appropriateness and efficacy of the existing oral health care services, including educational and awareness raising activities, are available in our country. However, a wide spectrum of oral health services exists in many urban rural areas in India. These services range from rudimentary and sporadic in rural areas to sophisticated and state-of-the-art in urban areas. It is unfortunate that there has neither been any systematic assessment of the need and form of educational activities and curative services, nor of the impact of the existing services on the oral health of the people. The vacuum of an effective monitoring and evaluating system is now being felt. The dental professionals are very keen to fill this gap between the emerging needs and the existing services. A strong need exists to understand the oral health care practices and treatment-seeking behaviors of people and to assess the existing oral health care services. An appropriate and relevant oral health policy for the country should address the local problems in the broad context of overall WHO primary healthcare approach framework. Ultimately, data needs to be generated to help address and improve overall health care of the people in our country. Since the quality of intake of fluorides has an effect on the dental caries prevention and control, it is also necessary to know the intake of fluoride through water, toothpaste, and other sources. This will help to bring out the area-specific policies to meet fluoride needs of the people. At the end, I believe I would have made you understand the importance of epidemiology as in developing the health policies and the importance on and its impact on all of us. It gives us the policies and helps us develop a stronger and a healthy nation. So these policies and this collaborative effort is very much necessary. And regarding your exams and writing an answer, I hope now you have an answer to the global scenario where you can describe the epidemiology per se and connect it to the global scenario using those 2-3 articles and the others from their references. And in the Indian scenario, again, you can show up the WHO the whole detail, as well as the Indian scenario and the other articles by Abhishek Mehta and other articles as well. Thank you all. Thank you for your kind attention. All the best to all the exam going students. Thank you so much.
Thank you, Dr. Priya, for this wonderful lecture. I think there are some queries. So would you like to reply
Sorry,
here? Or?
Most of them, ma'am. I think one is pending. I've answered most of them, ma'am. I think one is pending, but anyways, anybody wants to come up, I'm all hearts to answer.
Else you can type your answer if you are comfortable.
I have done that. I'll keep doing that as well.
Thank you. Thank you so much. Request organizers to please present the certificate of appreciation to her.
I request Mr. Dev to please present the certificate of appreciation to Dr. Priya Nagar.
And Dr. Priya, there are few questions. Just look at the questions, and if you are not able to answer right now by typing, maybe you share some material into that, right? Some reading material. You can just email me. I will attach that material in the chat as well as in the Telegram group for
I
the
will happily do that, sir. Happily do that.
Just,
all these articles which I've compiled, plus some other material I have, I will surely do that.
No, it will be really helpful for them. They'll be very happy.
I will be very happy too, sir. Thank you. Thank you for your support, sir. Thank you.
Pleasure is all ours. Thank you.
Thank you,
I
Dr.
request the moderators to please accept the certificate of appreciation. Mr. Dev, if you can project the certificate of appreciation to Dr. Parimala Kulkarni ma'am and Dr. NeerjaSingh ma'am.
Dr. Priya, there is one very important question which I could find in the chat, that was how to answer that: will India be ever caries free? So if you get some time after this session and before we start the another session, if you can give me some input and some material, it will be really helpful, because this question is very important for all of us as a clinician also, not as far as only the academic is concerned, the exams is concerned. So if at all you have something, just share that material with us.
Dr. Parimala, please accept the certificate.
Dr. Madhu, I think Dr. Parimala has just texted me also that she is on some important meeting. I'm not sure.
Right, the next certificate, please.
Yeah. Thank you.
Dev, Dr. Neeraj ma'am certificate.
Dev, you should make one presentation with all these certificates all together in one go, so that you don't need to sort it out, because you have all the schedule with you. So just make one PPT. So continuously you can keep flicking it, right? So it's easy for you.
Sure.
Thank you.
Thank you, sir. And thank you so much, the organizers, for this privilege. Thank you.
Thank you. So we'll start the next session by 12:45. 1 o'clock is the next session sharp. Thank you.
Thank you, everyone. Thank you, organizers. Thank you,
you.
Dr. Srinivas, Dr. Madhu. Thank you.
Thank you, everyone. Thank you so much.